This is session 2. So we're going to be getting into therapy, and Mike Chagalasian is going to kick it off, talking about ocular surface disease in eyes with glaucoma. And I don't know about you, but this is really a big problem in my practice. And I suspect it's something that is increasingly a big problem in your practice too.
Thank you, Bob. Thank you, everyone, for being here today with me, and certainly like to thank the TGF and the organizing committee for inviting me to be on this esteemed panel. As an optometrist, I'd like to really acknowledge Dr. Harmon's comments earlier this morning about the collaborative working together that optometry and ophthalmology can do. That's been part of my career at the Illinois College of Optometry, where I focused on glaucoma for 30 years, working collaboratively with ophthalmology and glaucoma surgeons. And so it's great to be at meetings like this where optometry in the audience, optometrists online, ophthalmologists as well, can share our thoughts and pieces of information to do a better job for our patients. So my topic might seem as one of the lighter ones today, but as Dr. Weinreb just said, it is certainly one of the, if you will, burdens that we face in our clinical practices every day. And I hope that over the next 20 minutes, I'm able to share with you things that I do to approach this problem, give you a little bit of background information about ocular surface disease and glaucoma, and then perhaps strategize about ways that we can all meet this problem for our patients in our practice. Here are my disclosures. And so here's a slide of a patient that I saw recently in clinic. We talked already about visual fields and progression analysis and OCT analysis and other technologies used in the diagnosis of glaucoma. But the slide that I put together there in the middle shows the other aspect of problems that my patients are frequently most complaining about when they come to see me in my glaucoma practice at Illinois College of Optometry. And that is that they are not comfortable. My eye drops bother me every day. And so that's a real problem. We need to address this more thoroughly, I think. We need to, of course, look at the cornea. We need to look at the lids and conjunctiva and fornices. We may need to look at meibomian gland and meibomian gland loss and dysfunction. So this is the intersection of glaucoma and ocular surface disease. We're going to review that a little bit and I think try to figure out better ways to manage this in our practice. I really appreciate this diagram from a number of years ago that look at the intersection of glaucoma, quality of life, and ocular surface or dry eye disease. And that is, again, really reflective of what's in our practice. And I think it's often just too easy for those of us, myself at least, is fully focused on glaucoma care and management and find it difficult time-wise and strategy-wise and maybe even comfort-wise to address the dry eye symptoms and ocular surface disease that is presenting in my patients. So, what can we do? What should we do? Let's try to address that a little bit. Certainly, I want to reaffirm that in this treatment section and for the program today, I am not going to address sort of the easy solution, which is to take your patients off their eye drops. Dr. Riolini will be obviously talking about that, and I am a full supporter of that. But that is not always the answer, obviously. There are still many of our patients that are on topical medications and need to be on topical medications, even if they weren't started on it. I don't have prescription writing data. That was a little bit difficult for me to get a hands on. But this is glaucoma market share data from a couple of years ago. It was put out in Ophthalmology Times, and it just shows you the percent of dollars that are being spent on pharmaceuticals versus glaucoma devices and MIGS and other things. And this may be skewed in many different ways. I'm just trying to make the case point that a number of our patients are still on topical therapies. We need to address that issue because they are often burdened and inconvenienced, and it may be impacting their quality of life. But certainly, I look forward to hearing from my co-speakers here about other ways to get our patients off of these, at least preservative-containing topical medications that can exacerbate their condition. So awareness and prevalence of ocular surface disease and glaucoma has been well known for quite some time. And in this 2008 article from Dr. Weinreb and his group, it really clearly identified the prevalence of OSD in the glaucoma patient population. And I sort of segmented out the mild to moderate stage of ocular surface disease and severe stage based on a variety of different tests that are often used in the assessment of OSD. That is the OSDI score, Schirmer testing that isn't really used too much anymore, lissamine green staining, and tear breakup time. And you can see that this is a real prevalent problem in our patients in our practice, and something we do need to attend to. And that's been continually reaffirmed since that article and from some before that, that the glaucoma medications can be associated with toxicities to the ocular surface, and that this is something we are facing. And unfortunately, I think we do have this tendency to try and dismiss this. You know, for patients that I see, I love it when they're at target pressure, their visual fields in OTC or CT are stable, and I can tell them that they're doing well. And yet they've got complaints to me that I need to address. And sometimes I feel that that's just another sidetrack in my busy day of trying to attend to my patients who are in perhaps greater need of more emergent sight-threatening problems. Following the publication, Dr. Fechner looked at an expanded and larger group of glaucoma patients and found that the severity of OSD was quite prevalent from mild to severe stages in a glaucoma patient population, and also identified that the number of medications lead to an increase, at least in the symptoms. In this case, the study was using the OSDI survey score, looking at patients' symptoms associated with dry eye disease. And that, as we will see, is often related to the preservative load that is in our multi-use bottles and medications. Other studies looked at associated risk factors for ocular surface disease. And again, not surprisingly, patients who are on more medications or have concomitant ocular surface disease, where the addition of a topical preservative-containing glaucoma medication pushes that patient over the edge, so to speak. You know, they may have borderline dry eye disease. We know that there's a variability in signs and symptoms of dry eye disease, and yet when we place them on topical medications, it becomes more problematic for them. And so we need to be aware of that. We certainly need to, again, be aware of other non-topical medication options for our patients and offer that. But still, these patients will continue to be impacted by dry eye disease as they get older. Meibomian gland dysfunction will go along with that. The use of topical medications will exacerbate that. A number of studies have looked at quality of life indicators. In this Australian study, looking at a number of individuals and using the QL15, GQL15 survey instrument, again, identify clearly that quality of life is impacted for our glaucoma patients. And after we've done our job of controlling their disease, stabilizing their disease, offering them the best and most current treatments, if they still have to remain on topical medications, there are other aspects to their quality of life, and we need to be aware of that and pay attention to that, because that's what they're asking us about. So again, another study looking at a different patient population, but also identifying that fixed combinations to reduce surface exposure, if you will, to benzalkonium chloride, the preservative that is commonly used in topical medications, should be encouraged to reduce and contain the onset or worsening of secondary ocular surface disease. So a number of studies have been looking at that. On the compliance side, this, I think, is harder to study and harder to draw direct correlations to compliance with topical glaucoma medications and the presence of ocular surface disease. So there aren't really very many good studies on this. This one on a veterans population in the Miami VA identified dry eye symptoms, PTSD, and anxiety were things that are associated with decreased compliance of medical therapy. And this study, maybe just a little bit of interesting in terms of what they were going after was the satisfaction or dissatisfaction of patients and their glaucoma treatment. So this was a European-based cross-sectional study of about 800 patients. They used a survey instrument, essentially asking how happy are our glaucoma patients. Fortunately, they often are almost 94% very happy and satisfied with their treatment. However, again, when you take a little bit of a deeper dive, there's lots of conjunctival hyperemia, there's ocular surface disease, there's positive conjunctival staining, there's symptoms upon installation and in between installation of their topical medication. So while they might be happy, and I'm sure, naturally they would be if their glaucoma is stable and well controlled and not progressing, the daily impact of topical medications is certainly a problem. And so when we look at our glaucoma medications, we know that in multi-use bottles, they have to be preserved. Our most common preservative is benzalkonium chloride. This is not the earliest work. There was work done in the 1990s. Before this, a lot of preclinical work identifying the toxicity from the BAK compound and its effect on cellular viability, conjunctival cells, epithelial cells. And so just a whole host of data started to emerge in the 90s and mid-2000s to reaffirm that this is essentially the issue. You know, we had just started using topical prostaglandin analogs with latanoprost in 1996, and then bimatoprost and travoprost followed. Initially, they were all preserved with benzalkonium chloride, and it wasn't really clear, was this a side effect of the prostaglandin analogs? Was it the BAK? So further studies really reaffirm that, you know, it's the preservative that's a problem. And it's pretty, you know, simple as that. And I won't go too deep a dive into the BAK issue here. I'm sure all of you are well aware of it, but, you know, a slide like this reaffirms that we need to look at the cornea. We need to understand that we're using agents multiple times per day on some of our patients, and that the cornea is impacted, the tear film is impacted, we're damaging and in some cases destroying and killing epithelial cells. The detergent properties of BAK will destabilize the tear film. It will affect the patient's quality of vision in addition to their quality of life. So that's, again, been well identified and well founded. And this tends to build up over time. There's an induction phase where some patients appear to deal with this fairly well and fairly, you know, fairly benignly. And then it continues to exacerbate and really become a main problem for other patients with all of these additional corneal problems. So here's my own little survey, if you will, from package inserts about the percentage of BAK in our current medications. And there are a number of other tables and guides out there. As you can see, I sort of separated it into the prostaglandin analogs and then most all of the other topical glaucoma medications. And again, it's just reaffirming what we're using on a daily basis. I think what we are almost, you know, have to use sometimes in this country, at least, with our topical glaucoma medications. And there is some variability there in the BAK concentration. As I alluded to earlier, if you can get by with lower or reduced BAK load on the ocular surface of your patients, they are likely to have less severe OSD and perhaps a little bit better comfort overall. It's interesting that despite all this knowledge and information about BAK, in the dry eye workshop study, part 2, the iatrogenic report, they identified that 38% of glaucoma patients were using tear substitutes, and more than half of them were with a preserved artificial tear. So I hope that's changed since 2017. There are obviously any number of very well non-preserved artificial tear substitutes, but to try and just, if you will, throw artificial tears, particularly preserved artificial tears, at this ocular surface disease problem in our patients is just not really a very good thing. I think we can do better than that. So my approach, I'll try to break this up into sort of the easy part and then maybe a little bit of the more difficult part, at least for those of us that are in you know, heavily concentrated glaucoma practices where we're dealing, you know, particularly I'm speaking to the glaucoma surgeons and comprehensive ophthalmologists that are dealing with a lot of glaucoma care, where it can be really difficult to get into some opportunity to provide dry eye treatment. But I think we can start with the easy stuff, which is identifying medications that are either preservative-free or BAK-free to reduce that preservative load and hopefully over time make a better impact on our patients' quality of life. Now, I will recognize, I'm not going to get into it too much, that some of these medications require the infamous prior authorization, where these medications are not fully covered, at least initially, by our payers and our insurance plans. And that really is, you know, almost the bane of our daily existence sometimes in clinical practice. And that could, you know, similar to along the lines of trying to use a branded medication. So I acknowledge that. I think we all need a collective louder voice in optometry and ophthalmology to reaffirm that preservative-free is the way to go. It's the way many, if not all, European countries have gone, widely available in Canada. I'm not quite sure why we're so stuck behind the 8 ball, so to speak, here with preservative-containing multi-use vials. So let's just take a quick look at what the preservative-free formulations are and just take a quick reminder and survey for everyone here. Again, I'm sure many of you are familiar with this. So preservative-free latanoprost is the newest to the market in the USA. Was approved by the FDA in December of 2022 and introduced last year. This is latanoprost, preservative-free. It's a pretty simple statement there. It was been available in Europe since 2013. As I explained earlier, it's widely available in many other countries. This is what it looks like. So I opened up a little package of preservative-free latanoprost. I took a picture of the unit dose vials and I'm like, is this all we're talking about? Why can't we just package more or all of our medications in preservative-free unit dose vials? Because that's really what it comes down to. Obviously, we want to verify and validate that the medication is equally as effective as a multi-dose bottle that contains BAK. You may be aware that there's work in the past that shows that BAK's disruption to the corneal epithelium allows for better penetration of some molecules, and there can be a slightly greater efficacy due to that irritation, if you will, to the corneal surface. But basically, here is preservative-free latanoprost. There's a host of data out there. I'm not going to go to all of the data. This is a pooled analysis from, I think, 5 clinical trials done primarily in Europe over the past several years, comparing preservative-free latanoprost to Xalatan with a 3-month duration. There is a slight advantage to the Xalatan in terms of lowering, that's the preservative-containing Xalatan, as compared to preservative-free latanoprost. This same study looked at other parameters for the ocular surface disease index, identifying an improvement in ocular surface disease when patients were switched from a preservative-containing latanoprost to preservative-free. And again, this is reflective of there's a lot of literature. Maybe it's not always the highest quality. Many of these articles are in open access journals. I'm not sure what that says, if the studies are just not designed right, or people don't care enough, or maybe it's just a more nebulous topic that's really difficult to drill down on. But there's just any number of studies that show, the IOP is virtually equal, hyperemia is greatly improved, and other metrics and assessments of dry eye disease are also improved by switching to preservative-free latanoprost. And here's another, again, collaborative study done out of Europe looking at increased tolerance for patients who were switched to preservative-free latanoprost. Sort of depends on what medication they were taking earlier. So again, a variety of different studies out there on latanoprost, but is widely available to us today, and I think makes a good option for a number of our patients. Of course, dorzolamide timolol preservative-free has been available for a long time. Again, obviously packaged in unit dose vials, and is, again, well known, I think, in the literature and in our clinics as an option for some of our patients. And we can now, again, pair that with a preservative-free latanoprost. Prior to that, timolol preservative-free has been available probably for 20, 25 years. Again, just offering patients who have, more extreme issues sometimes. We sometimes save these for our more aggressive, more severe cases. I think most all patients, though, would benefit from preservative-free medications. And if you look at BAK-free formulations, there are a number of them still available also. Brimonidine with purites. Now it's available generically, although what you get from the pharmacy sometimes when you write for brimonidine with its different concentrations and different availabilities with and without BAK preservative can be quite variable. Travoprost with an ionic buffered solution is also available. And here's data showing that it was equally effective to travoprost preserved with BAK. How much it helps on the ocular surface, I found a variety of pieces of information in the literature, some suggesting, substantial to mediocre improvement in the ocular surface, and this one here not really showing a clear improvement there. Again, I think it speaks to the difficulty of assessing this condition overall. And latanoprost with potassium sorbate became available in, preserved with potassium sorbate became available in 2018. It's not currently on the market, but my understanding is that may be returning to the market next year. So let's go beyond just, reducing the BAK load in our patients and using preservative-free medications. Let's at least address what can we do in our offices today as we assess these patients. And this is where your exam flow and your workflow and your setup and arrangement has to vary a little bit. You have to look at the patient separately from just looking at their eye pressure, doing Goldman tonometry, doing visual field and OCT. You might have to figure out a way to spend time to get patient history and symptoms, tear breakup time, ocular surface staining, tear volume. Those are the easy things I think to do in a patient with glaucoma and ocular surface disease. To move beyond that will obviously require some additional integration of diagnostic technology, osmolarity, MMP9 levels, meibomography, as I show you here, meibomian gland expressibility. Those are the things that really take time, probably can't be honestly integrated into a typical glaucoma follow-up visit. And what I often do is reappoint my patients after a quick screening to identify what their problem is. But even with that sort of simple assessment, there are a number of relatively easy things that we can do as eye care providers to improve our patients' ocular surface disease. Obviously, starting with preservative-free topical lubricants, some level of anti-inflammatory disease, because that's a big component to dry eye disease. You may use loteprednol, you may use cyclosporin, lifitegrast. There's new fluorinated alkanes such as Mibo that is particularly for evaporative eye disease. Demodex blepharitis. Now that there's a treatment that became available last year, one study showed that as many as 65% of patients in the glaucoma population may have Demodex collarettes and Demodex blepharitis. So again, opportunities there, environmental factors, that's always a big thing with our glaucoma patients. And finally, management of dry eye disease. This is really going to the next level. Bruder masks, heat therapy, meibomian gland expression, thermal pulsation or IPL. These are the things that really get to the heart of the matter, which is often meibomian gland dysfunction. It's certainly less easy, not going to be easily integrated into a busy glaucoma practice, but I think I'll have some solution for you for that. So what I do is I assess these things. I just make sure I try to carve some time out. I happen to work with students and residents. I want to make sure that we are covering all of our patients' concerns and issues. And when necessary, I'll start with some simple therapy. And then in many cases, I need to bring them back for a second appointment. And sometimes that's with a provider other than myself who really knows the dry eye disease and problem. And to that end, I recognize that everyone here is uber busy in their practices. We have a higher and higher demand for our chair time, and it's really difficult to fit all of this in. So if I can make a plug to the ophthalmologists in the audience, one of your solutions might be to refer to an optometrist who takes care of ocular surface disease, hire an optometrist who knows ocular surface disease, and they probably also will know some glaucoma and can work with you collaboratively in that fashion. But other than that, you're going to have to sort of remanage your workflow. And, for some that may be possible, for others, it might not be, possible. There is the option here with treating dry eye therapy. A lot of it is cash-based therapy. Maybe that's something that might work for your model overall. Whether or not an experienced technician can handle this for you, not quite so sure. And of course, having the right diagnostic equipment is really important. The good news is that improvement occurs quite quickly in 1 to 3 months by implementing these changes. So wouldn't it be nice to, hear really positive news from our patients rather than, great, my pressure's under control, my disease is not getting worse, but my eyes are killing me. And so unless you have the perfect MIGS option, laser option, non-topical therapeutic option, our patients are still going to be burdened with this. So I encourage you to continue to address this issue of ocular surface disease in our patients, and I thank you for your time today.